Oh, that's right. Hey, I'm Ann Eller. Yes, we're here this afternoon. We have a great show for you. Do you know the difference between home care and home health services through self-regional? Well, you're going to learn all about it today with our guests. I am blown away with the number of services that are available through the home health services. I'm blown away by the number of miles that they travel and how many counties are put together with this whole ensemble to help keep people in their homes, which is, of course, what people want. This home health care service is for those that are homebound. And today our very special guest is Elizabeth White. She is an RN, and she's got a whole lot of other letters after her name. So we're just going to say she's the Director of Home Health Services at Self Regional Healthcare. And our other very special guest this afternoon is Amy Lowe. She is the Home Health Outreach Liaison for Home Health Services. I want to welcome both of you to the show this afternoon. How are y'all doing?
Good, thank you.
Yes, I got your names up there, so you can't switch places now, okay? We're here this afternoon to talk about all the good things that home health services can do and what the hospital. Elizabeth, I'm curious how you got yourself into this job anyways. How did this happen?
I came to the hospital as a fairly new nurse on medical surgical unit, and maybe 2 or 3 years after that, the hospital purchased Visiting Nurses Association. It was a for-profit entity in Greenwood, and it became not-for-profit when Self purchased it. So I went over.
I could ask what happened. It was for profit. That's I know, because the hospital is a nonprofit
That's
entity.
correct.
Right.
That's very correct.
Right.
But I went over then, and that was in 1987, I believe, as a staff nurse. And they had 4 counties. We're up to 9 now. But I was the McCormick County nurse, one nurse for the county. And after that, I did that. I became called a patient care administrator, where you were over the nurses and handled scheduling, and did that for many years. But then I went into oncology for 14 and did chemo for 14 years and loved that. It's a great population mix between oncology and home care.
Wow.
Came back to be the director in 12 years ago, 2013.
Wow. That is terrific. Now, so did you do the oncology at Self, or did you
did. I've never left the hospital.
You never left the hospital. Good place to work?
Oh, yeah. It's been good to me. Nursing's been good to me.
Nursing is good. Nursing is good. And they have so many services available. Now, Amy, you are an Master in Sciences. That's what the MS stands for?
Yes.
Yes. Okay. And you are the Home Health Outreach Liaison with Home Health Services for Self Regional Healthcare. You were into sports medicine at one time.
Yes. So when I started at Self, I started in 2001. I was an exercise specialist at Optimum Life Center. I did aquatic therapy, industrial rehab for 19 years. And then my boss at the time, we were talking one day and said, I may be interested in something else. He said, well, I've got a perfect job for you. I was like, okay. I had no idea it was marketing. Just knew that it was home health, and he said I'd be good at it, and I love it. It's the best job. I do have the best boss, even though she's sitting right here.
And this is being recorded for in
yes,
perpetuity.
Thank you.
Yes, that's right. So
yes.
So what exactly do you do, Amy?
So title liaison, by definition is facilitate. So I try to facilitate a good relationship between our doctor's offices, hospitals, the community, our own home health team members, and the end goal is to get referrals or patients to come on service with us.
Sure. So now, how many professionals work for home health services?
We have approximately 125 team members right now. That includes skilled clinicians, billers, support staff. So in total, about 125.
Wow, that's a lot of people
It's a
then.
lot,
It is.
lot of
And
people.
I think you were telling me that it's 365 days a year, 24/7.
Correct. We never shut down. There is always a nurse on call. We work weekends. We always cover holidays. So
It is a Medicare requirement that a nurse be accessible
That the
24/7.
nurses- Wow. That makes it difficult, doesn't it? Does it ever create any heartaches or headaches?
I don't think so much heartaches as sometimes you have to reschedule, reconfigure if you have an illness or someone
Sure.
unexpectedly out. But the staff understand that it's an important piece of their job.
Well, that is terrific. So, what type of things do you cover in home health care?
What type of patient population?
Yeah. What type of things would you go into a home for?
For nursing, you can have a broad spectrum, and I think that's what's attractive to nurses, because you need to stay current with a lot of diagnoses as you don't stay in a certain population of patients. And they see anything from birth to 101 years of age and every medical diagnosis that goes along with that. But also they see wounds. They do IV therapy in the home. Those are what we consider a little more aggressive or a little more skill sets. Amy can jump in, but new diagnoses of diabetes, heart disease, stroke rehab, and then you get into the therapy side of it. You may have a patient for total hip replacement that needs therapy, but then there's a wound for some reason that nursing also comes in with that same client. So you have multiple disciplines on certain patient diagnoses.
Wow, that is terrific. So, Amy, from your perspective, what is the biggest thing that you feel about home health services? What are you proud to talk about?
our team members. We have got the most amazing staff, nurses, PTs, all the way down to our billers, our coordinators that are answering the phone. We just have a really great staff that love patients, love what they do. And it makes me teary-eyed because, I mean, it shows in everything they do. I get emails and calls every day on the different things that our team members go above and beyond for. We do a program called a 5-star shout out, so other team members can send me instances where a fellow team member has gone above and beyond. We get tons of patient calls saying how this nurse just really went over and beyond for them, and I get to see all that, and it's just amazing. I don't know that other places have that kind of love and compassion that our team does.
Wow, that's terrific.
Yeah.
Now, is everything based out of Self here as far as the central office, and then do people, because you said you cover 9 counties?
We cover 9.
Our central location for operations is Self at Tower Point, and then the Abbeville office that was health-related, part of AAMC, is still open, and staff can work through that division as well, but we're all part of Self Regional.
So you expanded your area back, what was it, Amy, you were telling me, I think in August?
October.
It's been a year anniversary tomorrow.
Yeah.
Your anniversary tomorrow, and here you are on the
Right.
radio today. That's pretty cool. So, what would you really like for people to know about home health services? There's a difference, I think, between home care and home health services. Am I correct on that?
That's correct.
Yes.
Who would like to explain the difference?
Well, I'll start because my knowledge is very basic, and then I'll let Liz expand. But so home care is going to be where you may get patient sitters. You could have a nurse, but it's going to be a private duty nurse. For the most part, it's not covered by insurance. It's going to be self-pay or private pay, and it's not a skilled need. It may be an illness or something that is much longer.
Long-term problems.
Yes.
Yeah.
Okay.
Where home health is going to be a part-time or intermittent skilled need, where CMS is very particular.
That's Medicare. Medicare
Yes.
services, yes.
Yes.
And to that point, Medicare has a responsibility to meet their budget, so they want to make sure we're doing the services we need to do, but we're not excessively staying in a home. We need to train the caregivers, teach them measures how to take care of their loved one, correct any knowledge deficits with diet, medications, whatever the diagnosis is, but then turn them over to their care or back to an outpatient setting. You know, if it is someone recovering from surgery, they can go back to outpatient for rehab once they're safe to go back there.
Okay. Now, home health services is for inbound people, correct?
Mm-hmm.
Yes, homebound. So CMS, which is Centers for Medicare and Medicaid Services, have two criteria that a patient must meet to be considered homebound. The first one is that they need to have a need of a supportive device, whether it's a walker, a wheelchair. They could have risk of infection to themselves or others, which was really large during COVID. So we had a ton of more patients during the COVID outbreak just for that single risk of infection to self or others. And then requires assistance to ambulate. That's the criteria one. And then the second criteria is that there exists a normal inability to leave the home, or leaving the home requires a very taxing effort to do so. That can include, like Liz was saying, wound complications, limited endurance, impaired ability to drive, fall risk, impaired gait.
And you can leave under the benefit to go to have medical attention or have your hair done. It has to be very limited purposes, though. If the person is able to drive successfully, then they need to go to services that are provided outpatient.
Okay. So that's another aspect of what this is about. This is really like being in the hospital, but not being in the hospital, right?
Yes.
It is. I mean, obviously, if there's acuity levels that require admission, we understand that. But one of our goals and what we're held accountable to is to keep the patient home once they come home from a hospital stay. And we're regulated on that. Money reimbursements tied into our successes of meeting those goals.
Mm-hmm. And it takes a special person to do home health, because we're getting invited into this person's home, their sanctuary, where they feel safe. And so the team members that go in there have to be of a certain quality that, you know, they're invited back in every day. There's some patients that we see daily, so they see those nurses 5 days a week, 6 days a week.
So now, how long can somebody be on this home health care?
That's a great question. It's really dictated by the acuity of the patient's health. If you have changes in your health, we may have started you for one diagnosis and something has changed in your health. That would give us a reason to continue services, okay? But if we accomplish our goals, then we discharge typically within a 60-day window.
Okay. I just wondered, because I know Medicare they have time frames that they're working under and that you can only have for so long. So, Amy, you made a really good point. What does it take for someone that is in home health care? Because I know there's a lot of people, you're absolutely right, that wouldn't want somebody coming in your home. So what type of person do you look for to work in home health?
Someone that is very non-judgmental and realizes that everyone's home is going to be different, everyone's personality is going to be different, and they just really have to have a love and a compassion for the people that they want to get better. I don't think anyone that goes into nursing does it for anything other than compassionate care, but for home health, because you're going into some very rough circumstances. A lot of our nurses will go for their first start of care visit not knowing the environment. They don't know who's going to be on the other side of that door, whether it's the patient by themselves or it's a patient with an angry husband, an angry wife, a
dog.
Yes,
I would think
yes,
that's probably true, right? Yeah.
Yes,
Very
they do
true.
ask that the animals are put up, but that's not always the case.
Right.
So Yeah, they have to be very flexible.
Yeah, well, I can relate to that because I know when my husband was ill, I don't think we had home related, but anyways, they came to the place, and I actually knew a couple of the people, and I was so embarrassed because my husband was really sick, and the place was a wreck, and I was going, "Oh my God, you can't come in here!" And they go, "Ann, we don't care about that. We care about Jeff." Right? Yeah,
That's true. We tell them when we interview, their home is their castle, and you have to respect their property. That's one of the rights of being a patient.
Right.
But we have to also protect the team members.
Sure. And I'll guess probably when you go in a house that you're looking at what could be safety issues for that person too, I would think.
Absolutely. And animals are a safety, but they're also an infection concern. You know, if you've got an IV site, the animal doesn't need to be near that site just for
They probably like to lick it. I can see it now. Yeah.
So sometimes that's a hard discussion to have with the patient because they find the animal to be their source of comfort and security.
Absolutely. So as we talk about this, I know that how many miles do you drive every year?
So last fiscal year, which was 24, we drove over 1 million miles.
Oh, come on.
I believe it was 1,104 miles. And that was before the consolidation.
Completely, yeah.
Oh, my God.
So health related themselves in fiscal year 24 drove over 411,000 miles.
Wow. So I expect you're going to see even bigger mileage this year, right?
Yes, I couldn't get a projected number yet for fiscal year 25, but I would imagine at least 1,500,000.
Probably. I haven't heard that
close
explained
to
the same way, but with the consolidation, even though we were together as a team 10-1, health related had software and patients we had to time points move through the system. So really it was January for everybody was a self-regional.
Self-memorial, okay.
Self-regional epic patient.
Right,
yeah.
exactly.
I am showing my age.
But that is amazing, and I mean you just have to factor that the cost of the gas, and don't you have cars that you send everybody out in and everything? So that's a big cost right there. Now, do you need more people, or are you satiated with what you have working there?
I will always say we need more people.
You mean patients, right, or
no,
staff?
I meant people like staff.
Oh.
Our positions are very comfortably staffed right now, but
well, that's unusual, isn't it? That's pretty cool.
It's a good problem.
Right.
Let's put it that way. We didn't know with the consolidation how everything would blend. We've had some changes over the past year, but we've worked through that and tried to make it leaner.
Right.
If that's what the call was, or more staff in a certain discipline if we needed it there. But I'm really proud of the team that's come together to be from two vast organizations, and almost were competitors in a sense.
Right.
And now we're one team.
One team. Well, that is terrific. Now, on the other side, do you need more patients, Amy?
I will always say yes to more patients. Not that I want anyone sick, but
yeah.
yes.
That's a fair question. I mean, we thought when we consolidated we'd be at 750 to 800, and now that we're settled in, we're staying around 625 to 650. So we can take more, and we will grow with that if we need to.
Well, that's great. So, one of the things we were talking about before we came on the air, and this is something to think about, was the effects of Helene, since we just came through that hurricane. And you were telling me that to some of the Helene, but then take it back to COVID, what you dealt with COVID, but during Helene you couldn't get into places, and you couldn't even find some of the people because they were in shelters. Is that right?
Yeah.
Correct. Going back to COVID, nursing census went up. Therapy census went down because elective surgeries had to be put off. And we had to use therapists in very unique ways. They did some COVID line testing and stuff to keep them busy while we recovered. But I think overall the team rallied. It was just a couple scary weeks of, are we doing it right? Do we have the supplies we need?
Sure.
But after that, it was just part of your daily routine.
Yeah. Exactly.
And then with the consolidation, we had a 10-1 go live, and Helene hit on the 26th?
27th.
27th morning, and that was a Friday.
Right.
And I very well remember I couldn't even get out of my own yard, and we're trying to merge these two teams together. So the Friday the 27th, Self was still Self and Abbeville was still Abbeville, but we had a nurse manager that scheduled the entire day by her generator that was solar
solar,
generator.
yeah.
And if we hadn't had her solar generator, it would have been chaos reopening. But she kept everything in line, and we kept trucking along. And the only visits we missed were what patients asked us to skip.
Yeah.
Wow. Mm-hmm. So I guess in those kind of situations, you have to be prepared for almost anything, huh?
Yeah,
Right.
It's like you prepared, but you didn't expect it. And then that day, it was beyond belief what we were trying to
and you said a lot of people you couldn't even get down their driveways to go see them. So I'm sure that created some anxiety for the people for the patients. Yes,
We had
Patients didn't have cell phones charged or
No.
phone, ways that we could contact them to say we were trying to come.
But we just would beat on the doors and try to get in. And we had one nurse that literally got permission from one house to drive through their yard to get to the house that had the tree down, because that's where
Wow.
the patient was.
that is some cool stories. I mean, cool stories of survival and everything along that line. Well, I tell you what, we are here today, this afternoon. If you've got a question, you can call on our new text and voice line, 864-332-9355. That's 864-332-9355. I guess one of my questions would be, how do you use the service? How do you have to be referred? How does this work?
So the referrals come from a provider. It can be a physician, a nurse practitioner, or physician's assistant. They're referred either, if it's a self-regional, Abbeville or Edgefield, they can refer right through our Epic database. If it's an outside facility, they would fax us the referrals, and then we would take it from there and get them scheduled. And our goal is 24 to 48 hours by the time we get the referral to see the patient for the first visit.
Wow, that's pretty amazing. Now, so they have to. A provider is going to refer them. Can somebody request those services, or do you have to go through a provider?
They can. If someone can call us and ask, but then we do have to have a physician order. So we can call the provider for them, or they can be coached how to talk to the provider to get us a referral.
Another CMS guideline is called a face-to-face encounter, so they have to...
Face-to-face encounter. Okay, go ahead. Sorry. Go ahead, Amy.
So the patient has to physically be in a room with a provider. You have 90 days before and 30 days after the referral that they have to have seen the provider, or the provider has put eyes on them for us to be able also to pick them up as a patient.
So lots of I guess we could say guidelines through Medicare, CMS, and if you don't check off all the boxes, it becomes very difficult.
It does.
Yes, very.
So okay, well, now do you do what type of things do you actually cover? What type of services?
So the number one is going to be our skilled nursing, and that's going to be our largest clinician base. Then we also have physical therapists, physical therapy assistants. We have occupational therapists, CODAs, which are occupational therapy assistants. We have speech therapists. We have 2 social workers. We have home health aides that are all licensed as certified nursing assistants. Those are the medical services that we provide.
Okay. All right. So pretty much anything that you could need from going home. Now, what about all the wheelchairs and, walkers and all that kind of stuff. Where do y'all fall on that? Do you help with any of that, or?
We're not a DME provider, so that's a physician order, and if they're coming from the hospital, it's usually part of the discharge plan. Physician office is the same thing. They may order them prescription, and then they go to a DME's.
Okay.
Examples of DME. Can you think of any?
Hospital beds.
No, I'm talking about actual service, the vendors.
Parish, home medical.
Well, I know when my husband was coming home, they wouldn't let him leave till we got the walker through their prescribed service.
Mm-hmm.
Yeah.
For his safety.
For his safety, yes.
Right.
Absolutely. You know, I never knew how, this is an aside, I never knew how helpful a walker is. Mm-hmm. It has a lot more benefit than just pushing in front of you. If you fall, you can use it to get up. It's an amazing piece of equipment.
Yes.
Yeah.
Definitely.
So, and I guess teaching people how to use this equipment is important, too.
I think it needs to be used correctly, too, or it can cause some problems. So you're right. It's very needed. And most patients do have, as she said, some type of device that we're servicing of some nature.
And the PTs are really good. That's one of their parts of their eval or their visits are going to be making sure that the walker is sized correctly to the height, that the patient's using it correctly. So just another example of what all they don't all just work with the body. They have to work with all the equipment around them also. So.
That's cool. That, I think sending patients home is always the best place for a patient to recover, right? We know that. But having the right kind of service that's there to help them recover is equally or more important than even sending them home, right?
Yes.
Because if you don't. Now, do you ever have any things where families are going, we don't need you here? I just am thinking, sometimes people they don't want somebody there,
well,
right?
That's their choice. We just want to make sure the patient is in agreement with them because they're the ones consenting to the treatment unless they're not mentally capable of doing that.
But
that's their choice.
It is their choice. So there are, I'm sure, situations like that. Well, we're going to take a quick break. When we come back, we are here with Elizabeth White, RN, and Amy Lowe, MS. There you go. I got it right out here for you. And we're going to talk more about this. If you've got a question or a comment, don't hesitate. Maybe we'll give out some telephone numbers, or maybe we have some stats that we could share with people about how vast this is. I think a lot of people don't realize how vast self-regional is. When we say regional, we think of Greenwood and just this surrounding area, but y'all are covering a lot bigger area than that, particularly with your home health related, right?
That's right.
So we'll be right back. This is WCRS. On the Facebook Live, you are going to hear some music. On the radio, you're going to hear some commercials. We'll be right back. Don't you go away. Take it away.
From WCRS Studios in Greenwood, South Carolina, this is Meet Me at the Diner with your host, Ann Eller.
Oh, that's right. We're right back here at WCRS. Break is over, everybody. Break is over. We're got to get back to business here now. Anyways, we are talking with Elizabeth White. She is the Director of Home Health Services, and she's been a registered nurse for 40 years. 40 years. I mean, Elizabeth, I bet you've seen a lot of changes in nursing over 40 years.
I have.
Yeah.
Different uniforms, different equipment.
Well, just the techniques, though, too, haven't we changed? And I guess you always have to keep yourself updated.
Correct.
Nurses have to go through an accreditation. Do they have to go through anything? Relicense.
Year, and then you have to keep continuing ed with that.
You have to keep
correct.
continuing ed. Mm-hmm. So accreditation and this type of thing, 40 years of being a nurse. Wow. What made you decide to become a nurse to begin with?
That's a great question. I think I never had any doubt it would be healthcare. Sometimes I thought about pharmacy, I thought about med school, but I came back to nursing because I thought it was best for me as wanting to be a parent or have a marriage and, that kind of thing. It was just better for me, lifestyle, but it was always going to be healthcare.
And one of the things I know, we have such a need for nurses, right? And of course, we've got Lander here producing good nurses. We've got a Piedmont Tech producing good nurses. That is a constant need. So as far as a career path, that's a great career path.
To my knowledge, it's stable for the next 50 years. We've got the boomers coming.
We got the boomers
out
coming
now, and not enough providers for the census of clients. Yeah,
right. So that's important. But, one of the other things that I think many people may not realize is that your home health services, it has to be licensed. Mm-hmm. But then you just told me you're going to be going through an accreditation service. What's the difference and why is that important?
Accreditation is a body you elect to take your survey process to a higher standard, and that's what they call it, as standards. You have minimal expectations under Medicare called the conditions of participation. And if you don't meet that, the accreditation body can cite you, but they also have a higher level of standards for every condition. So you're voluntarily asking for greater scrutiny with your survey to maintain your license.
So what does that mean for the patient?
It should mean very much more quality care provided to them. You have a department that has committed itself to staying at a higher level of quality and scrutiny.
So what is the process that you have to go through for this accreditation? I mean, do they come in and observe?
They do.
I mean, what do you have to do?
It's usually an RN. It can be a therapist, but typically they're nurses. They'll come on site for us for 3.5 to 4 days, depending on how fast they can get through. Because of the size of our organization, we already know what our survey days will be. She'll do 10 home visits, and with those visits will be the patient's medical record completely audited. Then they'll pick 7 more patients, so 17 records. They do all of our policies. They look through emergency preparedness that we've alluded to with Helene. Also, quality standards. We have a whole quality division, and they look at our processes. What have we audited and why, and did it make an impactfulness to the care? Wow.
So this is pretty intense. And will they now, one of the things we were talking about off the air is that self-regional, this home health services is the largest in the state.
For not-for-profit.
For not-for-profit.
Since the consolidation, we became the largest nonprofit home health agency in South Carolina.
Wow. So, we talked about 9 counties. Now, the hospital covers 7 counties. Mm-hmm. Is that right?
That's correct. And we added Anderson County and Greenville County to our services.
Why would you add, I'm just asking, why would you add Anderson and Greenville?
Abbeville Hospital System already had those 2 counties,
Oh,
and it
okay.
makes a lot of geographical sense. If you live in Abbeville, you're touching Anderson County.
Right.
The Greenville is a little more of a drive, and they had the certificate need already there. It was already part of the state observation and oversight, so we kept it.
Wow. Well, that's I would think that's huge.
Yes.
Yes, that is huge. So how many miles, we talked about this, how many miles?
We cover 5,000 square miles.
God almighty.
Yes.
That's amazing.
And it shows in our cars. The miles on those cars are.
So does Self have their own shop to keep all the cars up and everything?
We have great partners with certain providers to do our tires and do our oil changes and try to get the staff back on the road. I
Right.
mean, it's important that they don't lose time taking maintenance of the car.
Right. But I mean, I'm just thinking,
Yeah.
I mean, you almost could, we mean, despite speak to Mark here, they might need their own
Little pit crew. Yeah.
pit crew to go out there.
Because I think we counted we're up to about 70 fleet cars. And they just got 12.
We'll have over 80 cars once we get through this next realignment.
So how many people work every day? Roughly, just roughly. In this.
Right at 100, because our weekend is less than 20 employees. So 100 or 110 probably.
Wow. Wow, that is totally amazing. And I think, that goes to the commitment of Self to provide great care. Because like you said, you don't have to take this accreditation level to another level, correct?
That's true.
So when Self wants to have that and keep that, and then they're willing to take on Greenville and Anderson, I mean, I'm amazed. I'm amazed actually you don't have more people. I mean, when you really look at how many miles and what you're traveling and everything, and over 600 patients that you deal with.
Liz and the managers do a great job of assigning clinicians to teams and counties so that the nurses and the therapists aren't driving an exorbitant amount of miles, that they're staying kind of local to their Saluda County.
We have geographical assignments of staff unless we have vacancies we have to cover.
Sure. And I guess if you think about it, a nurse is going to go to one house in the morning, then by lunchtime she may be at another house, and she may be another place early afternoon, this type of thing. So
they have weighted different patient care. If you're admitting somebody, it's a lot more complicated than once they're established. But they're contacting probably 6 patients a day on average, and driving.
and
an
driving.
hour.
And then they have all that paperwork to do
Exactly.
too, right?
Mm-hmm.
I wonder, I don't even know if you can answer this question, but since AI is such a hot topic, how is AI impacting that at all or not?
They do not have permission to use AI. I can see that it changes healthcare.
Right.
They don't dictate. That's something I hope in the future the staff can dictate, and maybe AI would help protect them.
Right.
But at this point, it's not part of their routine.
It's not part of their
I'm sure they're
routine.
exposed in different capacities, but
Right. Well, I just was thinking, like, you need to go to this house first, go to that house second.
now they have route planning within Epic. They have a device called Rover, and it helps them route plan. But you also are required to meet the patient's preferences. So if the person furthest out of the way wants to be first, we try to do that. We can't always do it, but we try to.
How accommodating are you to the patients? That's a
as
great
much-
question.
We have to be. I mean, we're judged by that. So yes, but there are skills sometimes that you have to make the priority. If you've got to get blood work that dictates how much antibiotic you take back to a laboratory, that's going to have to probably be your first visit. You don't want the blood to go bad.
Well, that's another thing. Now you've got to transport blood and stuff to get it analyzed, I would presume, or something.
That's another sign of great team members that we have, because we'll get a nurse that has an urgent lab need that needs to be taken to the lab, and they'll send out a message saying, is anyone in this area that can pick this up for me and run it back? And, they'll get several responses. I can do it. So the teamwork that you have to have in home health is incredible. And fortunately, we do have that. We have amazing team members that work together so well.
Well, I would think you would have to, and if you didn't have that, it would probably be a disaster, wouldn't it?
I can't imagine.
I want to go back to, Amy, you were talking about the shout-outs, the stars that you do, that your staff and that you do. Tell us a little bit more about that. We probably have people that are tuning in now who might not have been listening in the beginning. I think that's an amazing way to keep staff motivated, isn't it?
It is. And when I got to home health, it was very different than my outpatient setting. We were all together for 8.5, 9 hours a day. A lot of times we would eat lunch together. And so you got just really close. You got to see the ins and out of everything. And when I came to home health, I just noticed, because everyone's so spread out, you may not see a team member physically in the office for a couple weeks. So it was really hard to, I wanted to make sure the morale was up. So we came up with a 5-star shout out program where you can shout out your manager, you can shout out a fellow team member. We've shouted out some doctors before.
And in a positive sense, shout it out.
Yes. Yes, always in a positive sense.
Right,
yes, absolutely.
Right.
So then every quarter, the team members with the most shout outs will get 5-star of the quarter. So they're recognized in social media by our wonderful marketing team. They're recognized in LinkedIn, our News to Know, which goes to all self-regional. And then they get just a little Cersei. They get gift cards or Amazon cards or whatever. But some
massage.
I wish. We'll have to
That would
think
be a
of that
good one.
for
That
next,
would be a good one,
yes,
wouldn't it? Yeah.
for next fiscal year.
But then they're rolled up into the annual event of picking a team member of the year.
Yeah, so
that's pretty impressive. That is
Yes.
pretty impressive.
just a recent shout out that I was sent, I think last week, was one of our physical therapy assistant, a nurse sent it in saying, I just want to let you guys know what so-and-so did. We had a patient that I believe the patient is recovering from spinal cancer, doesn't have any support at home, lives by himself. So our physical therapy assistant went in that morning for his visit, got him out of the bed, did his therapy with them. Then he went on to see the rest of his patients and came back to the patient's house to put him back in the bed and make sure that he was tended for the night.
Wow.
And it wasn't...
That's above and beyond. He
Yes,
didn't have to do
he
that,
did
right?
Right. And it wasn't, someone local. I believe it was quite out of the way for him to go back and see that patient and help him get in the bed. But
Well, one of the things about what you're doing, this is almost like working from home, right?
Yes.
That same type of remote working. You're not in an office where everybody
Yeah.
sees each other all
Right.
day long.
then we had another, I got a message from one of our nurses that she got a call from a patient after hours saying, my power just got turned off and I have a wound vac, and the wound vac has to have electricity. So the nurse and our social workers tried to come up with a plan for her. The nurse actually drove back to the patient's house with some chargers that would help her get through the night. And then the next morning, our social worker called all around and was able to get their power bill paid by Gleams. And so the power was on the next morning. But
That's above and beyond.
yes.
That is above and beyond.
And this patient was just really struggling. So I think that extra just assistance and going above and beyond really meant a lot to them. I can't imagine, being homebound and then losing power, not being able to work, not knowing how I could pay it.
Would have adversely affected her progress if she couldn't have gotten the vac
Correct.
back on too. So.
Right.
But I hear stories like that weekly.
Are you serious?
Yes. Yeah. We get patients that, especially, I think this was during Helene maybe, where power was still off, but the patient needed a fridge for their medication, and so the social worker worked with them to be able to have a way to keep their medication refrigerated. I could go on and on. But
Well, I mean, those are things that as patients we don't always see, right? Because our case is very separate from everybody else's case. So I think this is kind of invaluable information. We just had somebody say this has been very informative this afternoon on our Facebook
Thank you.
Live,
Wow.
right? So that's what I think makes a difference is people, so many times we look at the hospital, it's over there, and you only use it when you need it, right? And then you're not really happy when you're having to use it, right? And now we're talking about home health care, and so home health services, and what a difference that can make in people's lives. So let's talk about, because there may be people sitting out there that are going, I didn't know that was available. I know, Amy, you even told me sometimes providers don't even know the things that are available through home health services.
correct, and I don't know that all of the providers maybe understand the requirements that we're held to by CMS guidelines as far as how long we can even keep a patient. That's very, they're very strict. As it has to be that the patient, for therapy standards, is making progress. For nursing, obviously, we've talked about it has to be a skilled need. But it can't just be that we're going in just to be,
Check on them.
yes, yes,
It's got to be for a purpose.
correct.
For a purpose. So again, how does, just as we get it, we're almost finished here. So how does somebody get these services if they need it? Now we've talked about the fact that as you're checking out of the hospital or whatever, your provider usually is. But what if somebody knows of a case where that isn't the case and they feel that they could benefit from this? Do you want to talk about that maybe one more time, how that works?
A family member or a patient themselves could call us directly and ask for assistance. Then we would call their provider with their permission.
With their permission?
If they don't have a face-to-face, that's going to be an obstacle. We're going to have to work through that. After Helene, you had telemedicine approved face-to-face, but Medicare is going to shut that back down where you have to be in the physician's office.
Why are they going to shut that down?
They gave us more leniency than they promised. It was supposed to have stopped last year, right after the COVID emergency stopped.
Oh, when that finished, right.
But that is a hardship if you're bedbound and you require an ambulance just to go see a provider. That's a hardship. So
Absolutely.
we have some wonderful doctors who have made home visits with us to see the patient in the house.
Boy, that reminds you of the old days,
does.
doesn't it? Yeah, when a doctor
does.
went to your house. Yeah.
So that's great that Greenwood's small enough that you can get a physician to feel comfortable to go with us and meet us in the house.
Yeah. We also get referrals not only from our hospital, but the rehab hospitals, Greenwood Rehab, and Med Rehab, skilled nursing facilities we work with, and then all of the assisted living facilities in our area. We typically can see patients there.
At the assisted living places.
Yes.
Okay.
Several years ago, Medicare allowed nurse practitioners and physician assistants to sign orders, and that has opened up a lot of avenues to get orders quicker. We used to have to only be through a physician order, but we can use the mid-level practitioners now.
Wow. So these are all things that are available to you. We thought it would be a great idea to have home health services come out here. I think one of the things that I've learned today, they're not looking at your house. No matter if you're saying, oh, I can't have these people here. They're not looking at your house. That's one thing that I learned. And the other thing is that it's a really big group of very caring people that want to see you succeed in whatever your healthcare issue is.
Yes.
Would that be,
Yes,
would that be correct?
absolutely.
And that SELF has the largest nonprofit home health services organization in the state of South Carolina.
Yes.
And when you think about it, we've got Columbia, we've got Charleston, we've got the coast. For SELF to be here in the upstate with that's pretty impressive.
Yes, I agree.
So, Elizabeth, what else would you like everybody to? I'm sorry, Liz. What would you like everybody to know about home health services as we finish up here today?
I guess for me, it's just a broad spectrum of care. We have staff that have to be comfortable whenever they're walking into a home, what that diagnosis is, and be comfortable with the limitations the home can provide. Sometimes you do have to move them to an emergency room, but we try to keep them out of there as much as we can.
Sure. All right. And Amy, what would you have to say here as the face of the public relations here, the liaison person for home health services?
All of a sudden I've become speechless. I don't know. Just that if you have any questions about home health, we are here to answer it. If you don't know if you would be a fit for home health, feel free to call.
What's
there's
the number
no harm.
to call? What's the number to call?
Yeah, the number is 864-725-7600.
Okay. And is there any extension, or that'll take you directly there?
That's the main number, and then our operators will connect you to the correct department.
Okay, so 864-725-7600?
Yes.
That's for home health services. I highly recommend that if you've been listening to this today and you're suffering, and I mean, a lot of people sit there and suffer and don't realize that services are available, correct?
Correct.
That's true.
Yeah.
And this is a Medicare, through a Medicare provided, it is paid for by Medicare. Self, of course, is there to help assist in any way that they can. And since you have put this together, 9 different counties, 5,000 miles area that you cover, with only 625 people. I'm impressed. I am impressed. Or 125 people. 125. You average 625 patients.
Yeah.
Seems like you'd have more than that, really, doesn't it?
I guess, but to me, it's massively big. So,
Yeah.
I can see it growing to 1,000.
To 1,000. Wow. And that means that's going to be more getting people on board.
Yeah.
So this is a great program, Home Health Services. This is why I wanted to sit down and talk to these gals and let you know about them. And if you have questions that weren't answered here today, please call them 864-725-7600. Elizabeth Liz White, she is the director of home health services. She's been with us today. And Amy Lowe, who is a Master of Science with her home health outreach liaison, home health services. Now, let me ask you something. On these shout-outs, can a patient do a shout-out for a nurse?
Yes.
Or
we do get a lot of, the patients will either call
me.
Liz or our...
They can call the main number and
Yeah.
speak to anyone, but sometimes they'll call and ask for me because that's in the admission packet.
Okay.
Yes.
But when they have seen that, so you get patients too.
Yes.
Well, it's been a real joy having
Thank
y'all
you.
here today. I
Thank
think we've
you.
covered a lot of ground. Thank you so much for coming out.
Thank you for having us. One other thing, we do cover all insurances. We don't ever deny a patient for their ability to pay. So we cover all insurance. We have uninsured, and we have a self-pay program. So that's also unique to our home health agency. Not all agencies can say that.
Wow. Okay. So you will work with a patient, well, just like the hospital does, because it
Yes.
is a nonprofit. They
Yes.
always treat and then worry about how we're going to get
Correct.
paid. I think a lot of people don't realize what a benefit that is to our community to have a hospital that is able to and will treat anybody.
Yeah.
That is a very big benefit. So same in the home health services. So give them a call. Check it out. If your doctor doesn't recommend it, but he's sending you home, tell him maybe you should call, right? Right. There you go. 864-725-7600. Thanks, everybody, for tuning in. This is WCRS Radio. I'll be back in the morning. And Penny got groomed today. She's getting real excited with her seat over there, taking over the show. She thinks she can do it. We'll see. That's going to do it for us today. Bye-bye, everybody. Take it away. Cue the music. And thanks, everybody, for being here.
Thank you.
All right.